Doug is the director of CDC's project to develop a national model aquatic health code and was the interim vice president and treasurer of the conference for the model aquatic health code. He is currently the executive director of the CMAC. Please welcome Doug Sackett.
Thanks. Good morning. What I want to talk about this morning, and I'm going to jockey between glasses here and figure out what's going to work here, but this presentation is we want to talk about the benefits and the potential deficits of having this federal model code from a health department perspective, and how can such a document benefit a local health department and public health, but they still have the ability to maintain state and local jurisdiction. So you get this federal code, but you don't want to have that usurped and be forced into doing something. You've got local, state perspectives that need to be addressed. And then how might the bottom line public health be impacted in the short term and long term? So I want to cover those various aspects in the presentation today. So let's see. So currently, if you're a public health or state health department, local health department jurisdiction, when you've got your regulations on the book, the development is done at your local level, typically. If you're statewide, you're developing it. County, city health department, you're developing it. So you have that responsibility and the workload to do that. We heard about John from the industry perspective, and depending on the local health department, not all jurisdictions will seek and incorporate input from the aquatics industry. I really don't know how pervasive that is. I know in New York, when we were developing regs, we had some input, but it's not like when we developed the MAC, where we sat down with our industry partners and we hashed it out. You may have had some things floated out for general public comment, but it wasn't like true development of the product. And that's probably going to be variable across the country and jurisdictions. But and also from a health department standpoint, there's a significant staff resources involved in doing the research for a code change, preparing the documentation, developing the code language. We're working through the whole process. It's time-consuming resources, and I'm sure the folks in public health out there would agree that there's diminishing resources, the budgets are being cut, you're doing more with less, sometimes programs are being eliminated, so we're all kind of stressed and to do more with less. At the same time, this incredible workload to stay up to date and relevant. And then again, the local health departments are responsible for defending. You're going to have a code change. You have to defend the proposed changes from a needs, benefits. What are we trying to accomplish by it? What are the benefits of it? And also the cost. What's the impact on the industry, the community by doing that? All that research and resources, our health departments own that and have to develop that. From the MAC, in comparison, if you're looking at the MAC and adoption of the MAC was developed by this expert group, a consortium of national and international stakeholders. We had folks from Canada and other countries involved in the development of this. So in contrast to local, whether it be city, county, or state, only your resources. The MAC had the benefit of this huge range of experts around the country and the world in some cases. And unlike at a local level where it may be just health department folks primarily developing it, we had substantial industry participation in the process. I think that process we're seeing, we heard from John, that process results in better acceptance by the industry. And as John said, we had 71% of the public comments, and a lot of those were industry input, were accepted. They're excellent revisions, made the code better. So again, this collaboration with all the stakeholders in there in developing this is a benefit. And in contrast to what you have to deal with on a local jurisdiction standpoint. When we look at defense and how needs, benefits, and all that, one strong point, I feel very strongly about this, is the benefit of the annex. For those that may not be familiar with the Model Aquatic Health Code, we've got the code language is one document, but the annex is a separate document that's basically the why behind the what. Every code section, to the extent possible, is here's the level of chlorine. The annex gets into what is the data, what's the research, what's the rationale on selecting that level. So when you're up there trying to defend it from a needs standpoint, the benefits standpoint, the annex is there, provides that documentation, and hopefully, if we've done our job right, it's very clear and should be clear and compelling as to why this is in there and why it should be in there. So, and to keep it current also. Technology changes, and I know this can be very frustrating to industry. You've got a local jurisdiction, here's our code. Things change pretty quickly in the aquatics industry. New products, new rides, new features, new types of designs. It's not spelled out. It's not addressed in local code. So what can happen? Sorry, you can't do it. We don't address it. You know, that's not good for anybody's business. So with the model code, that's why we've got the 2-year update. It allows for research that's been done to demonstrate certain products may be good or new ways to deal with things. We can incorporate and keep up to date on what's going on and make sure that the code addresses it. We don't want to just say, no, sorry, it's not in the code, you know, come back sometime later, don't bother us with that. I think that creates an awful lot of ill will. But from a health department standpoint, you're really, it's a difficult situation. You may not want to say no, but it's not in your regulation. You don't have any way to evaluate it at a local level, or it's very difficult to. So you're forced to make a decision. So it puts you in a bad situation too. So if the model code, if you can stay current, hopefully can eliminate that type of situation. Talk about if you have this federal standard or federal guidance, how does the local health department maintain control? There's a lot of nuances to local jurisdictions. But as John had said, the MAHC can be adopted in whole or in part. I mean, in a perfect world, ideally, if we have the perfect product, have the same code, all the language adopted uniformly across the country, then there's the consistencies there. But we know that's not a reality. There are local nuances. There's history. And just use New York as an example. We've had the hotel, motel, tourism type industry and the supervision levels there. That's been going on for decades as to what, you know, from what a health department perspective, what the impact on the tourism community years and years and years ago reached some compromises in how we approach that. It may be different than what the MAHC says. So all of a sudden, when you have decades worth of an understanding of how we're dealing with it and then say, sorry, that's all out the window, we're going with the MAHC. So having the opportunity to pick and choose can be extremely beneficial to address local concerns. Again, it can be modified to address local issues. But again, if we've done our homework right, if the annex is complete, it should be defensible. Why should it be modified? Unless like I said, unless there's those types of local circumstances where the impact, but from the science and the technology, why should, let's say, a state choose one level of chlorine residual that's different from the MAHC? If the MAHC has the research there, if the annex provides the documentation, what's the justification from deviating from that? So, hopefully that is, as folks are looking at it and adopting it, that looking at that any modifications or deviations, there's good justification for it. And again, the annex provides the support for the requirements when the jurisdictions are working with their local stakeholders. So it can provide, with the MAHC, can be quite a resource for locals when they're looking at, even if they're modifying it, they can still look to the MAHC and use the annex's materials to help defend where they'd like to go. Benefits, short-term benefits of using the MAHC, again, if you're a health department perspective, and overall we're looking at the MAHC and adoption, we could be reducing pool code violations and closures. Again, if we have the stakeholders, we have the operators part of the process, we have good defensible rationale on there, and we're following good sound guidance and criteria that we're going to reduce some of these incidents. Again, using it as a risk reduction approach to pool design and operation. We tried to be performance-based where possible instead of prescriptive. And so we're looking at, the big picture, what it is we're trying to accomplish, how do you get from A to B, and avoid being prescriptive. So goes along with this risk reduction. What are we trying to accomplish? What is the risk? How are we reducing it? What are the different aspects that come into play? Improving the effectiveness of pool inspection programs. Again, is another short-term outcome. Improving data collection through standardization. All of us, there's some model tools, and I think Jason's going to be speaking of that later on today's presentations, but we all, from health departments out there, have our own inspection reports. We collect information differently. I know Michelle Lafsa from CDC has done some studies, and it's been published in MMWR on results of inspections. One of the trials and tribulations of trying to do this is this state has their inspection report collects the data this way, this collects it a different way. They may not all collect the same information. They collect it in different ways. So it makes it difficult, if not impossible in some ways, to analyze that data so that you feed that back into the system. Okay, we've got a reg in place. It's designed to accomplish this. How do we know if we've accomplished this? We have to have surveillance and analyze what we're seeing. If you can't analyze it, you don't know if you're accomplishing what you're intending to. So the standardization of collecting the information is important. And expanding the use of that data, like I said, to make decisions, not just here's the reg, put it in place, go about your business collecting and doing inspections. Have we accomplished what we wanted to do? Are we improving the way we're doing business? And decreasing resources used for creating and regularly updating the pool codes. That should be a benefit. As your folks are stretched thinner and thinner, you dedicate less time and resources to get an up-to-date code. Long-term outcomes, reducing outbreaks of waterborne illnesses, reducing drowning incidents, reducing injuries for pool chemicals, and swimming-related emergency room visits. All this translation of here's the code, here's compliance, here's our inspection, here's the operators in the industry, all buying into this. Following that, we should see a reduction in all of these items. So, didn't want to get up here and say, here we are embroiled in the MAHC development for all these years. John, there's been a number of us been involved for years and years and years. We've got, want to make sure we didn't have tunnel vision. It's intuitive. This is where we want to be. This is what we think the benefits are. Want to do a little reality check. So we had some outreach to some of our state and local health departments to do, again, this reality check, ask some questions. So the first question was, are there benefits of having federal model code? Obviously, you heard me and John say, we think there is, but what does the health department say? Here's some of the responses. The code's scientific, research-based, and it is defensible. There's a benefit. One of the identification, too, is that we have a lot of contractors that apply to do work outside the state. Having a federal code, so you've got more of a consistent, uniform code, it helps ensure uniformity. And then, importantly, too, in the bottom, we'll not have to reinvent the wheel each time we update our code. So this is actual recent current feedback from some of the jurisdictions. We also want to know, okay, we said that presumably it should reduce resources if you accept that. So that's another question. Are there cost savings, whether it be resources or actual financial dollars and cents that you can label to your local code development process, revision process by having the federal model code? Over time, again, it was likely to save resources because we won't have to, so we won't have to develop from scratch each time. But the MAHC, but there was a concern that the MAHC is such great detail that they'll have to go through it first, identify if any local objections exist. But then using the FDA food code was difficult the first few years for those that are familiar with the FDA model code, very comprehensive document. But now it saves significant time and resources. So it's like, yeah, we think there's a code saving. There may be initial, there's going to be some pain at first to come to understand it. It may be a lot more comprehensive and complex than existing codes, but over time that's going to even out. And another comment, the annex will serve as the rationale that are not in the codes now. So every time we do a rule or act revision, it must reinvent the wheel. The wheel's been invented with a MAHC. So again, some potential savings. We also want to say, do you see any negatives to having this federal model code? There were some concerns you can see if it's too restrictive and doesn't allow for local decisions to be made, it could be a problem. But they acknowledge that because it's not a mandate, it's not a concern. So there's potential concern, but because the way we've structured it, it's taken off the table. And also, federal code being a model code in the right direction, it's not the VGB, a federal law with a mandate with no money associated with implementation is a problem. But the industry standard of care will likely be the MAHC, and it'll be used in court cases. So again, some potential concerns, but hasn't seen that it's going to be realized, doesn't appear to be realized. So The future, we're encouraging everyone to become a member of the CMAC so that you can drive future revisions of the MAC. You can be part of the process. Your local concerns can be addressed. You bring it forward. So it's not a few people speaking for all. It's everybody part of the process. So it's collectively our product. Don't hesitate to contact us at the CMAC if your jurisdiction health department has questions about the MAC or MAC adoption. We're prepared to help out, answer any questions, and help you work through the process if we can. And we think that all stakeholders working together, we can preserve and protect one of America's greatest pastimes. We've heard about, continue to hear about the health benefits of aquatics and engaging in aquatic exercise and recreation. We're not, from a regulatory standpoint, trying to put an end to that. We're just trying to make sure that everybody can do it in a health and safe manner. And I think we, health departments and operators in the industry share that same goal. So as John had in his slide too, here's some information on where you can get, here's some contact information for further information. So I think that was the last slide, so we'll